Hey, welcome everybody. My name is Taylor Henrik. I'm here with my colleague Sarang Patel.
Hey guys.
Hey, so today we're going to be talking about bipolar disorder. We're going to be talking about a complex disorder that we treat on a daily basis, how we might manage clients that have this disorder, and what we might do with medication management.
Let's get it.
So today we're going to talk about bipolar disorder. Let's dive in on a specific topic. I think that this is going to be a good one for us. You know, we can all pull up ChatGPT, Gemini, and just look up what the diagnostic criteria for bipolar is. Specifically, when we're talking about bipolar, there is two different types of bipolar, right? Disorder. There's bipolar 1 and bipolar 2. You can add in other mood disorders like cyclothymic if you want. But I think the key focus for us today, let's talk about bipolar disorder. What does it look like? How does it present? And how can we help clients with their challenges, right?
Yeah, real world stuff.
Real world stuff. We're not looking for the definition, all right?
Yeah.
Again, anybody can look that up. Let's talk about when we see someone who's struggling with a mood disorder, okay? So first and foremost, bipolar disorder intimates that there's more than just unipolarity, right? So unipolar depression is just major depressive disorder. Bipolar disorder, a lot of people talk about depression with mania, is how it used to be classified, is bipolar. Inherently, there's going to be two different mood states, right?
Yeah.
Okay.
I think an example I give is that a lot of people know what depression is, right? You have low energy. And we talk about the criteria you need to meet based on textbooks, but the real world stuff for depression is you don't have to really meet every single criteria, right?
Correct.
Low energy, low motivation. Anhedonia, which is loss of pleasure in activities you like doing before, right? Feeling withdrawn, feeling isolative. Hopeless, helplessness. Appetite, up or down. Sleep, up or down. And these criteria are pretty simple. You kind of follow those. If you meet most of them or it's just stressful for you, then you would say, hey, maybe we have some depressive tendencies here. Cool. So we treat that. The example I give to patients is, it's like that weighted scale. You have depression on one end. Another end, you have a mood disorder.
Okay.
Don't call it bipolar. Just call it a mood component.
Okay.
And again, there's different criteria like we talked about, like you said, but there's mood swings, racing thoughts, irritability, being impulsive. And impulsive is a hard thing to talk about because a lot of people will say, well, what is being impulsive? So probably you and I, this is kind of cool. But for me, being impulsive is I always say, well, remove Amazon shopping because it's one click buy and we all impulsively buy on Amazon. But promiscuous behavior, spending habits, gambling, certain things that you know that I am more impulsive than I should be. And I would argue it's not just impulsive actions, but also impulsive thoughts.
Okay.
Right?
Yeah.
So you go through mood swings, yes. Racing thoughts, yes. Impulsivity, yes. Irritability, more than normal, yes. Do you feel like you have energy spikes? Yes, right? And obviously, if someone knows they have bipolar disorder, they might say, I've been manic before. Or, I feel like I've been on top of the world before. Generally, I would argue, this is me clinically, right? If someone has some of those criteria and it's distressful, I'm not necessarily labeling as bipolar disorder, but I'm treating with medications as if it's bipolar disorder or bipolar tendencies.
Absolutely.
Right?
Yeah. And I appreciate your approach. I want to tell you how I walk through it as well. If I'm sensing that there's something more than unipolar depression, my first thought process is my goal is not to put you in a box and put you aside. I don't care about the bipolar label. My concern is the symptoms. How distressing is it to your day-to-day life and how much is it impacting you? Okay. So think about a straight plane, right? I think about like a straight line. That's neutral or euthymia, right? So when you're bipolar, you're going to have dips into depression and you're going to have these peaks or troughs, right, that go up into hypomania, mania, and accelerated phases. So when I talk to a client, I always tell them my goal is to put a roof on mania and a floor on depression, all right? My goal is to get you into that range where you feel like you're in control all the time. All right. You're not controlled by a medication. We're not trying to mask your emotions. We're trying to curb the excesses.
Yeah.
So when someone's deeply depressed and they're in a persistent depressive state, I'm concerned, right? Months on end where maybe they were previously manic and they're not on any substances or there's nothing else inducing this manic episode. But that crash afterwards, I get really worried about. So for me, I want to dig them out of that depression as soon as possible. And I don't want to do anything that's going to elicit a manic episode. So curb the highs, curb the lows, and try to help them be in a stable range where they can be what? Gainfully employed, healthy relationships, take care of their day-to-day. Those are the keys for me. I don't care about the diagnosis so much. If I see the symptoms, I'm going to hedge my bets and I'm going to try to treat appropriately.
Yeah, I think it's actually really important you say, I don't care what the diagnosis is, right? I tell patients that all the time. It doesn't necessarily matter what the diagnosis I put today is, as long as you're feeling better. And I know people argue either way on that, right? A lot of clinicians say, well, no, you have to have it right. I understand you want to get it right. But we talked about this before. When you use a medication and when we treat the medication, it's like a broad spectrum antibiotic. We hope that we're able to cover you so no matter what you're covered. So if we do have something missing, we're okay. So I would say that, when we talk about that pendulum here, we talk about the weighted scale, depressive features on one end, mood features on one end, right? How I'm explaining to somebody who may be naive to medications is we can put you on antidepressant medication and we're going to control the depressive features. Depression's high, moods are high. If I put you on an antidepressant medication, I'm putting weight on the scale, but I have a tendency or a risk factor to make this scale go up. So you can feel more irritable. You could be manic, right? You could feel more impulsive, racing thoughts, whatever it is. So then we say, well, let's use a mood stabilizer, right? Let's use something else as a mood stabilizer. So let's put weight on this scale. So you hope this weight comes down on the mood issues, and you hope that it kind of balances out.
Absolutely.
Right? So you have an antidepressant, now you have a mood stabilizer. You hope you can kind of control that. The next argument, and again, I want to see your opinion on this too, is then you say there's an antipsychotic medication, which that term sounds so scary, right? But there are medications we know that are dopamine modulators that regulate dopamine compared to these two medications. That is a medication in the middle that puts weight evenly, let's say evenly, on both sides of the scale.
Correct.
So either I manage two medications, which just works all the time to balance the scale out, or I put one medication to put even weight on both ends, and I'm just managing one medication.
I'm with you.
Right? So then someone, when they're sitting in front of you, is like, okay, that makes sense.
Yeah.
So then you together make a conclusion about what you want to do.
Right. Right. You're exactly right. And the old adage, the classic model was to go mood stabilizer, right? And I think more classically, it would be to achieve that because the goal is you're just looking for a stable range. You're looking for something to smooth things out, right? Think about a steamroller just kind of steamrolling through your symptoms. But the idea that you're describing with an antipsychotic, again, antipsychotic, name of class. These medications are not just used for psychosis. That's, again, a myth relating to these medications. It's something to bosh or put the kibosh on because these medications do so much more. You said it. Dopamine modulators, but these medications also work on norepinephrine. They work on serotonin. They're going to work on other neurotransmitters as well to a lesser extent, but the big one obviously being that they're dopaminergic. But these medications will inherently treat depressive symptoms, right? In the right setting, certain medications. They will help in the state of a mixed episode, which can occur in bipolar disorder. We can dive into that. And in a state where they're manic.
Yeah. So I would argue that, when you use dopamine modulators, let's go with that, or antipsychotics to make it simple, right? They typically work faster. And I argue that I think that they are actually more effective. I'm not saying that an antidepressant and a mood stabilizer can't work.
Correct.
It works all the time.
All the time.
Great. But I found that at some point, for someone who has bipolar 1 or bipolar 2 or bipolar tendencies, we typically end up sometimes getting to that point where we need something that works on dopamine.
I think early on in our careers, you may have heard the same thing. But I was told when I was being taught in psychiatry, and again, I don't think this is wrong, but from a simplistic sense, what I was taught in psychiatry was don't use an antidepressant in the setting of bipolar. Did you ever hear that? Right. In practicum or in real life,
All the time.
you use antidepressants all the time in the setting of bipolar. Because if you don't, you're going to be in a persistent state of dysthymia or dysphoria. As long as you have your balance was a great example. You have something balancing it out. Antidepressants have a place in a mood disorder.
Yeah, in real life they do. The idea is that we are trained on a textbook. We are trained on literature and studies, and I understand that completely. Like, it works so well. You follow that. That's what we're built off of. 100% I get it. Then when you start practicing clinically, you see after 9 years, you're going to see, man, like someone is on atypical antipsychotic medication, something that regulates dopamine. They have to be on an antidepressant as well. Their features aren't there. Their features are not controlled for depression, I mean. So the argument is that, well, someone who has bipolar disorder, I can't put an antidepressant medication because it can make moods worse. No. I think clinically from what I've seen is that if your antipsychotic medication covers enough of the mood symptoms,
Correct.
if it does, then you can use another antidepressant as well.
Exactly.
And see where they're at. And then the question comes in from the patient, well, How long do I have to be on this medication for? Is it lifelong? Be real. I don't know.
Mm-hmm.
I'm not sure if it's going to be a couple months, if it's going to be a couple years, but we follow up every month. We see how you're feeling. We'll see how triggers are going in your life. And then we'll determine if you have to take one away or if we want to keep both of them.
Very good point.
But if I could tell the future, I'd go to the casino.
Absolutely.
You know what I mean?
Absolutely. And the other thing that's changed over the course of the last couple of years, you mentioned just over the course of our young careers in psychiatry, dude, think about all the different medications that have come out for depression. You're talking about medications that are no longer just serotonergic, no longer just SNRIs, SSRIs. You have NDRIs. You have medications that are doing more, that are not just like a unimodal medication. They're now multimodal. So again, you're classically treating depression, but you're also getting other benefits. So there's going to be a place for those medications in the setting of a mood disorder.
Yeah. I was talking to a therapist last night, just off the cuff that some of the company, we're talking about it. And it was the idea of that, who do you trust to be your prescriber? I think is a really big thing, including therapy as well. But you don't necessarily want someone that's just only textbook savvy, that knows what the textbooks say and what literature says about medications, or someone who says, I know nothing about that and I only know about real world experience, right? You need like a middle ground.
Yeah.
And I argue that I think that a lot of people at Pure, I think, are in this middle ground, which is really cool. But I argue that even if someone in my family had to see somebody, I want that prescriber to be in the middle ground. Because I don't think you fully control mental health, especially bipolar disorder, if you're on the way left of just textbook savvy or way right of just clinical.
Absolutely.
You have to be in the middle.
There's got to be a union between evidence-based practice and using anecdotal experience from what you see time and time again.
Yeah.
I mentioned all the time when I treat kids, I use examples of what I've seen work, and I'm going to tread incredibly lightly. With adults, it's the same thing.
Yeah.
I have seen this. I have been through this. Here's how I'm going to help you. Absolutely. We are not simplifying psychiatry to a sense where, just throw this at that. No. We practice evidence-based practice for a reason, but there's also a level of using your knowledge and being intuitive about what you've seen and sharing that knowledge. You and I do a lot of education of other APPs and other individuals in behavioral health because we're achieving nice outcomes. I think we're doing a good job. And I think a lot of people around us are doing a phenomenal job.
Yeah.
So why not share that knowledge and why not be a part of that think tank? Hey, this worked for me. See if it works for you. Gain your own experience and then let me know. Let me know how it went for you, right?
Right. Yeah, I agree. I think the other conversation with bipolar disorder, and this is kind of semi-controversial, but I'm going to bring it up anyways, okay? But one renowned
love the
psychiatrist,
controversy.
right? We have to do it. One renowned psychiatrist said this one time. And yesterday when I was in a different clinic, internal medicine clinic, we're talking about this. Think about if there is a spectrum of bipolar disorder.
Okay, there is. Yeah.
There's bipolar 1, there's bipolar 2, but there's also 3, 4, and 5.
Okay.
So we all fall on a spectrum. Every single person that exists falls onto a bipolar spectrum, which I agree with because you should. You do have depressive episodes. You should feel sad at times. You should have emotions. You should feel angry, irritable. You should have all the levels of emotions that are there. They're there. You should have them all.
Okay.
Right? I mean, you want to experience them. Not to the point where it's distressful, but you want to experience emotion still. So if we all fall on the spectrum of 1 being severe, 5 being symptoms of normal emotions, but not distressful for you at all, you're
Okay.
good.
Okay.
Doesn't mean you're manic. If you go with that motto, then okay, whenever you see a patient, you have to rule out a bipolar disorder across the board and assume that we all fall on the spectrum here. So if you're 5, you're good.
There's no diagnosis.
There's no diagnosis because we don't have it in literature right now. But in real life, it's like, yeah, you do get angry, you do get sad, you do get upset, you do have emotions. You're good. You're great. It's not distressful. Great. As you move closer to 2, it's clinically FDA, DSM-5. It's there. It's a diagnosis now of, hey, it's more distressful. We recommend to treat it with medications more intensively. And 1, bipolar 1, then you do that.
Absolutely.
But realistically, how many patients have major depression and have a mood component? They
Right.
just have mood swings.
Right.
Or they say, I can't sleep at night. And when you ask them why they can't sleep, my mind is always racing. My mind is racing all the time. Well, okay, that's racing thoughts, right? So you have some symptoms of that bipolar disorder, that mood symptom, not all of them. Mood disorder, but not all of them. So then you're probably what? Bipolar 3? So it hasn't gone to the point where we can say, hey, you're officially bipolar 2, But many patients fall into this category if you have depressive features and you have some mood features. So we're going to treat it as if it's bipolar disorder, even though it's not the same label.
Absolutely. And you could call bipolar 3 cyclothymia, right?
Yeah.
It's like a softer version. There's something beyond depression, but you can't really put your finger on it, right?
Exactly.
Yeah. So, your classification here makes sense. It does. Normal emotional range, some depression with some irritability,
Right.
cyclothymia, bipolar 2, bipolar 1. And these symptoms make sense. And if you think about it as a cascade of severity, it does make sense. It does. I understand the point that you're trying to make, and it's a good picture to make because as you get towards one, you got to treat. Or you don't have to. You can absolutely live however you want. But in our minds, when we start to think about classification, it's, hey, let's avoid those extreme highs where we're a risk to self, risk to others. Let's avoid those extreme lows where we're a risk to self and others. And let's help you get control over the emotions.
Yeah.
I don't want anybody to feel emotionless, right? Biggest fear for me as a provider is for someone to feel emotionless or numb. So when it comes to medications, my goal is I want to help you regain control. I don't ever want you to feel like you're out of control. I don't want you to ever feel like you're spiraling or you're so high that you don't understand some of the consequences of your potential actions.
Right.
Risky at all times.
The goal is not to be numb, to be dulled, to feel like people can say, wow, you're on a medication. No, the goal is to be to a level that you want to be at. That makes sense, right? That's safe. But I argue that if as a clinician, that's why I think our intakes, right, our new patient packets at the clinic don't ask you, what's your diagnosis? What are you here for? As a clinician, you need to rule out everything. Assume someone has bipolar disorder until you rule it out.
Absolutely. Especially with depression.
Especially with depression. Assume they have anxiety until you rule it out. Rule out our things, assume they have it, and then rule it out. Then you're okay. Then you're fully covered, right? Otherwise, you don't even look for it.
Absolutely.
And then we wonder why bipolar is the most underdiagnosed mental health condition for many years. Yeah, that's why.
Right.
Because when you have a label of depression, now your chart stays with you forever, depression, and you're not changing it.
Absolutely. The complexities that come along with this disorder definitely exceed other disorders that we may treat. There's a lot to unpack, and we're just scratching the surface. This is just like a baseline. Hey, here's your primer if anybody's interested in talking about a mood disorder. There's a lot that goes into a bipolar disorder, but the misconception that somebody with a mood disorder cannot be functional, cannot be gainfully employed, cannot be a member of society to whatever degree they want is definitely false. Individuals can thrive with bipolar disorder. And again, it's not just, okay, let's throw medication at it. It's not as simple as, yeah, let's find the right antipsychotic. No, that's not the point we're making here. The point is medications can be utilized. Therapy services can be super beneficial. And then every step that the client takes in their own life has to be pretty intentional. And then these individuals can be really, really successful.
Yeah.
And we see it time and time again. It can come with any disorder. This can be said for other disorders as well. It's just when there's a bipolarity present, when there's two different mood states that you're oscillating between and you can get trapped in the middle, it can be very difficult for a client.
Yeah, I think the job falls onto us as a clinic as well, right? To then say, hey, like, you have to follow people more frequently because if I say I'll follow up with you in 3 months, a lot can happen in 3 months.
A lot happens.
Like a lot happens.
Yeah.
And then someone, let's say they missed their appointment, you have to reschedule. Like real life stuff happens, right?
Yeah.
Whatever happens.
The Lions fall out of the
Lions
playoffs.
out of the playoffs. We're all like, I'm not seeing anybody. It happens. So then you're like, well, now I'm going to see you again the next month or 3 more months. Now it's 4 to 6 months gone. You can't do that.
No.
I always tell somebody, I'll see you in a month. Worst case scenario, like you're doing really good. It's a quick appointment. Yo, that's good. Like we're going to chill here. No one's ever like, no, don't check up on me. Like, I think the idea is like, let's have a conversation. If you need me, I'm here for you. Let's just do it.
Yeah.
It's quick, it's simple, and we're okay. We're covered. But you typically catch things before they spiral, especially with bipolar tendencies.
Totally agree. I totally agree. And I think that our recidivism rate or our attrition rate with hospitalizations are better because of that.
I can't even say that.
I love this model. I love checking in with people. If my clients ever get sick of me talking, I'll be like, hey, I'll see you in a couple months. No problem. But if somebody feels good or inherently it helps them for them to hear that I care, like I want to check in on them and I wholeheartedly mean that, I'm going to do an appointment every day with my clients. I like when people check up on me. I love when you ask me how my family's doing. It's the same idea. It's a quick appointment, but hey, I know wholeheartedly now because you've been hospitalized or you've been on medications in the past that you're doing well. Perfect. Put it to bed. I'll see you next month. Have a great day.
It's the biggest thing is just follow up and being transparent with it.
Absolutely.
Fully.
Yeah. Well, hey, thanks for joining us on The Pathway. I hope you enjoyed our discussion today on bipolar disorder. See us back soon and hope you have a good day.